first of all, big congratulations to all of you for clearing the IDCCM theory exam. I heard the paper this time was also tough, but still all of you cracked the exam and you did really well, and you have made all the faculties very proud. As you already know, Dr. Tapas Sahu and Dr. Sanant Kumar are the course directors, and we are the other faculties who are taking care of the IDCCM course. The theory journey obviously was very difficult because there were a lot of modules and a lot of topics to be covered module wise or subject wise, the portions wise. And then finally we had 2 mock exams which were quite extensive. Very thankful to all the faculties with me who had taken time to make sure that apart from the debrief videos which we had for the theory exams, for your practical exams also you have adequate debrief videos, so that you get quite a good idea about how do you approach the questions and answer the questions. So both the mock exams are also very extensively covered, which makes us really happy. And all I can say is, see, the modules we can give you, the materials we can give you, we can give you our time on WhatsApp, which we have requested since the start, that any doubts, anything, message in the WhatsApp group, we are available for you. But the final effort has to be by you. You have to put the effort, like your 100% of your effort right now. And for practicals, the main thing is the gap between your theory and practicals is very less. It's hardly like 4 weeks around. So you have to 3 to 4 weeks. So definitely you have to put in your best, give your best and perform well. IDCCM is not something so difficult that you can't clear. You just need the right guidance, the right path, and prepare smartly. So I would request that for practicals, be active in your WhatsApp group, post your doubts. You bug your faculties as much you want possible with your questions and doubts, and keep us on our toes. That will make us really happy, because we won't be knowing at what point or at what which topic you are getting stuck. It's sometimes very difficult. So we try to give a general overview. But if there's some particular topic which you want to know in detail, or there's any particular question which you want to discuss, or table vivas or anything, put that up in the group so that the faculties available in the group will accordingly handle those queries and doubts. But your involvement has to be 100%. Like how you guys have been involved for your theory, you'll require more than that for practicals, because practicals is mostly related to the clinical part which you are covering in your ICUs daily. So if you have cleared the hurdle for theory, practicals are not going to be very difficult. But considering that you have prepared for the practicals in a very smart way. Okay. So know our faculties which you already know for our theory: Dr. Sashi, Dr. Hariharan, Dr. Ankit, Dr. Arun, Dr. Tilak, and Dr. Aditi. They're the same faculties will be there for your practicals also, right? So how does your practical exams happen? So basically you will be allotted centers. Few people may get it in their own cities, or some people have to travel to other cities. Like for people in Bhubaneswar, usually in Orissa, they go to Calcutta. That's the nearby center. So when you go there, you have 2 clinical cases. You will have around 40 marks each, and you have 6 workstations of 20 marks each. Know that in the 2 clinical cases, overall you have to get 50% marks to pass. And even in the in the workstations or table vivas, you have to get separately 50%. But there is a clause in that ACLS and airway stations, the passing is mandatory. That's why they make it compulsory for you to do ACLS for everyone. And people who are non-anesthetists should have done an airway, difficult airway and basic airway course before giving the exam. So 2 clinical cases where out of 80, you should at least get more than 40. And 120 marks of table vivas, 6 separate tables will be their workstations, where you should get 60, but you should pass in your ACLS and airway. Now, if you look at the course schedule, what have we tried to do? So the gap is very less, right? After theory, between theory and the practicals time. So there is not much time for us to go through all the cases with you. It will be very difficult if we sit and discuss each and every case. So what we have done is all the possible table vivas which can come for your exams, we have already pre-recorded these videos in Zoom, so which are extensively covering all your table viva topics. What we got a feedback from the previous batch was most of the table vivas what we had covered in our videos were asked in the exam. So they were very well prepared. In few centers, they might ask you about ECMO and RRT in case like in their center, if they really want to put those questions for table vivas. But understand that if you have gone to the level of ECMO and RRT, that means you have performed really well. So you may get 1 or 2 questions on RRT or ECMO in the table vivas, or they may not even ask about it. So don't worry about the things which may be rarely asked. Be sure about to answer the things which are being asked regularly. Okay. Apart from that, what are we going to do in the next 2-3 weeks for you? I'm sorry for the April part. It's actually now in the September, October. What are we going to do? We are going to do one simulation mock exam where the faculties itself are going to simulate an examiner and a student, where we'll tell you that when these questions are asked, how are you supposed to answer? What is the way you should be, framing your answer in proper points? And one of the faculties will be overlooking this whole simulation mock exam and telling you the important points to remember. In the last 2 weeks, we will be asking you for slots where we want you to give 2 mock practical exams in the style of Idccm, where you will have one at least long case and you'll have 6 spotters. So it can be any time in the day. So give us your slots, which Navneet and Bhagyashree will be contacting you for that. So give your slots, and according to that, that should be matched with the faculty slots, and we'll take these 2 mock exams for you. I will request not to skip this mock exams, because once you face a dummy examiner, which is like us for the faculties in this right now in Trics, when you give the final exam, you won't be scared anymore. You'll know how to face them. You'll know what type of answers they're expecting. So apart, I will request not for you not to miss the simulation mock exam, and also not to miss both the mock exams which we'll be conducting for you, which all the 7 faculties are going to take, and go through all the table viva videos which we are going to share with you in the Google Drive. Go through that. Everything has been covered, right? From ICP waveforms to pleural fluid analysis, ascitic fluid analysis, hemodynamic monitoring, ventilator graphics, everything what can come for your exam has been extensively covered. We cannot particularly cover all the cases. So what we can try is, we request you to go through all these cases, which are the possible system-wise case lists I have mentioned. These will be also there in the Google Drive given to you. Read books. So there are apart from your basic theory books, like, so theory you have actually adequately read right now for the Idccm theory exam. So either it's your O's or Washington, but apart from that, try to read a case-based book so that you know when they ask you questions, what you're supposed to answer. So there are many books, one of them being case-based review by Atul Kulkarni sir. It's a very good book, which very helpful. It's not about reading theory, but it's about reading more like, if this question comes, what are they expecting as an answer from you? So you can go through that, and also through your base foundation or theory book, which you have gone through. So any doubts about these cases, please post in the group. As the time is very less, after a week of from tomorrow, we are starting the course. So once you register for the course, you'll get all the table vivas. So towards the last 2 weeks, we'll keep all the mock exams, because the time is very less, right? We don't want to keep the mock exams right before the exam so that you're very worried and tense. Don't get demotivated at all with your answering, or if we are strict during the exams. It is all for your good, so that we want you to commit all your mistakes now in front of us, so that in the exams you all pass with flying colors. Okay. So this is roughly the case list system wise. I have mentioned what all possible cases can come. And sometimes this case presentations also, if you know, apart from the table vivas, the 2 case presentations you have, it won't be a single case. So it may start as a main system case. Like, for example, it may start as an acute coronary syndrome. And then further on, when the case progresses, so initial vignette may be acute coronary syndrome. You'll have 7 to 8 questions on that. And then the second vignette, when you go through, so this acute coronary syndrome now might have progressed into, like, the patient must have went into NIV failure, and then patient got intubated. So there will be some big questions about mechanical ventilation. Now, the third vignette can be that this patient had a prolonged stay and the patient has developed ventilator-associated pneumonia. Now, how do you go about it? So third vignette can be ventilator-associated pneumonia. So it's not like all the 3 vignettes will be also related. The vignettes will be actually put up like an ICU case, what you see in your ICU. A traumatic brain injury coming up with lung contusion, prolonged stay, tracheostomy, then going for VAP or some nosocomial infection, sepsis, septic shock. So that is how the case can progress. So in case the first part of the case, if you feel you have not done well, don't lose heart, because you still have 2 good vignettes to score really well. The questions are very specific and to the point. So stick to the point when you're answering. Don't deviate, because there's not much time for you to go in detail mentioning the explanations or physiological basis. You just need to answer to the point. So these are special topics in further vignettes, like the case can suddenly go to post-cardiac arrest, or it can be end-of-life care. If it's a pancreatitis, they can talk about abdominal compartment syndrome. Any ICU prolonged stay, mention about VAP or CLAPSy, or any post-op esophageal surgeries or gastric surgeries. It may go to refeeding syndrome. You can have C. diff infection mentioned in the second part, rhabdomyolysis. Then you can have weaning, and then finally ICU acquired weakness. So these topics are actually usually the second and the third vignette. The first vignette usually will be from these topics, the main system topics. So table vivas, usually you have 6. So one is ACLS and BLS, second is airway, which these both are mandatory to pass. Third, you will have drugs. Drugs can be vast. So, and the best part is for all these table vivas, when they show you a photo or a drug or anything, they will have 2 questions fixed for that. So don't try to talk extra. Just answer those questions and finish it up. Okay. And if you're getting stuck somewhere, you tell, I don't know, so that they can move on to the next question and you don't lose marks. Fourth will be instruments. Fifth will be ECG, ABG, and imaging. Sixth will be hemodynamic monitoring. So all the table vivas also have been systematically divided. So table viva list can be all these things: oxygen delivery devices, fluids, imaging, body fluids. So we have covered all these things in proper videos: airway devices, Rotem, TEG, and then art line, muscle relaxants and drugs, ACLS, BLS. So all of these you are going to find in the video. So our videos are around, I think, if I'm not wrong, 20-21 videos. So all of these things have been covered adequately in detail. So any kind of success needs preparation. You definitely need to prepare well. We can just give you the material, assistance, support, or clear your doubts and queries, but the effort has to come to you, because we are not going to write the exam. You people have to write or appear the exam. So you should be confident. You should prepare well. Get all your doubts cleared. Put up all your queries. Do all the mistakes you can right now in front of us, so that there you are confident and you will definitely do well. At least I find theory is more difficult when it comes to IDCCM. Practicals is slightly easier because it is something which you are doing in and out daily in your ICU. Okay. So any questions if people want to ask? Thank you. Or else we will be moving to Dr. Sashi, who will show you how a mock exam looks like. Any doubts if people want to ask, or we can move on to the mock exam, which Dr. Sashi will put up, a sample mock exam of how that a paper will be, the practical day.
So, Dr. Alisa, if there are no questions, I will be just taking 1 minute of your time before Dr. Sasi discusses about the exam pattern and how the exam, the mock exam will be happening. I am in, you can say, in the core committee. I know how the exam normally happens. So one important point that the examiner will find lot of ways to actually fail you, because it's not a very difficult task to pass in the practical exam if you know the path, the correct way how you will be cracking it. So I would request all the attendees today, if they are appearing in the upcoming exam, so they should know that yes, there is a format, there is a process, and there is like one of the exam way that normally the examiners normally adopt during that one day. So they have to tick all the checklist. So if you know it at least 60% to 70%, so it would be very hard for them or difficult for them to fail you. So you need that mantra, you need that the way how you will be at least cracking that maybe 2 hours 3 hours of the exam. So that is point number one, and that will happen only if you are participating, you are giving multiple exams, and that would be happening only if you go through a mock test series in front of somebody talking to you, somebody asking, somebody rectifying you. So that is point number one, as Dr. Alisa has already told. Now the second point, believe me, the ISCCM is planning to make the examination pattern more and more difficult in coming years. So that is something I am now telling, maybe unofficially, but you have to clear at the earliest. Otherwise, the pattern is going through a very strict, I would say, the supervision now also. They're thinking that maybe we need to make little bit more difficult. So this is the best time. Go for it, clear it, and make it a thing of the past. Thank you.
I apologize for the voice, sore throat, but I still like to manage this. So as Dr. Alisha and Dr. Sir has already told you, this mock practical exam is basically how you understand the question and how are you going to answer it. So for this, the mock simulation exam which you're going to keep at the end as before your exams is very important because we'll be discussing this live with us. So we will be able to rectify your mistakes and we'll be able to tell you where you're going wrong. So it will be very easy for you to answer this mock practical exam. The case discussion, if it is in person, like virtually when you're going to take the Zoom videos, it will be very useful because the previous session when we had done this, everybody has given us a positive feedback that when they were able to realize where they were going wrong, like initially, like if you ask for the differential diagnosis, they used to get stuck up in the differential diagnosis, but they would be able to answer all the questions. And there'll be a lot of persons who will have the fear of answering the examiner at the first go. So the fear of answering the examiner will become little better when they have already given a mock practical exam to 2 or 3 persons whom they don't know as strangers as examiners. So here I will be discussing today about one case and few spotters and how you need to answer in the exam. So, and there'll not be much time in the exam, so they'll be giving you only a short duration for you to read the question. And once they move on to the next slide, you will not be able to come back to the previous slide. Or if they, in case they tell you the case or they give you, like few of the hospitals may not have like 10 case, like if they have only 10 cases, one case will be a live case, one case will be a case which they'll be given you as a simulation in a small paper where there will not be much details. So you need to read the question in detail and you have to remember before you go ahead and answer the answers how they ask you. And important thing is the case will start with a vignette, a small vignette, and then you will be proceeding with multiple vignettes from there. First, it might start with a respiratory case, but it might end up with a ECMO, CPR, or anything it can end with. So you need to know everything, even if it's a cardiac case or a GI case. As Dr. Alisha was discussing earlier, your case can start with a respiratory case, but it can end with a C. diff diarrhea. So you need to know about everything for a case discussion. Next slide. Bhagyashree, next slide. Yeah. So here I'm going to present a case that the case is 57-year-old admitted to the ER with a 3-hour history of chest pain and shortness of breath, known diabetic and hypertensive on regular treatment. The GCS is 15/15. Heart rate is 145. Temperature is 36. BP is 80/30. Peripheral capillary refill time is 5 seconds. Respiratory rate is 35 minutes. SpO2 is 91% on 10 liters of oxygen via face mask. On auscultation, patient is having bilateral crepitations. ECG and X-ray I'll be showing you in the next slide, and patient is shifted to ICU. So here when you read this small vignette, you need to remember that patient is a 57-year-old diabetic hypertensive, patient is tachycardic, patient is hypotensive, hypoxic, and patient has bilateral crepitations. So this is a regular case which you're going to see every day in your ICU. So you will know what is the diagnosis. So we will see what are the caveats you might face when you try to answer these questions. Next slide. So here you can see there is an ECG and there is an X-ray. So I think by this time all of you might be guessing. Here we are not able to ask you. Usually if in the live simulation, we'll be asking you to describe the ECG in detail. We'll be asking you to describe this X-ray in detail. And you need to tell ECG, 12-lead ECG showing the changes. And X-ray also you should be able to tell whether it's an AP view or a PA view, what is seen in the X-ray. You cannot directly tell this X-ray shows pulmonary edema. And the examiner who's going to come will not be happy if you answer like that. You need to tell it's an AP X-ray or a PA X-ray, overexposed, underexposed, showing
bilateral infiltrates. So all these has to be explained in detail. And you should tell it could be probably this is my first differential diagnosis. Next slide. So these are the first vignette you will be getting. So in this first vignette, you can see there'll be 5 to 6 questions like what are your provisional diagnosis? Describe the ECG pattern. What is the classification of MI? What are the investigations you will be asking? And what will be your initial line of approach? So this will be in your different. So here, obviously, you know the answer is MI with pulmonary edema, but these questions may not be in the same line, same page when they show you. So first question will be what are your provisional diagnosis? So you need to tell it. My first provisional diagnosis would be MI with pulmonary edema. My second diagnosis would be this. And then they would tell, please go ahead and describe the ECG pattern. So depending on the timeline and the ECG changes, you should be able to describe the ECG pattern. Next slide. So here you can see the ECG changes which are being shown. So there can be hyperacute T waves which can occur between minutes to hours, ST elevation which can occur up to 12 hours, the development of Q wave which can occur 12 hours or 12 hours later, and ST elevation with P wave inversions which can occur in which can occur in the duration of 2 to 5 days. So it is important for us to describe the ECG changes which is in your ECG at that present with the timeline of presentation of your patient. Next slide. So the next question was, what is the classification of MI? So you should be able to tell type 1, type 2, type 3, type 4 and type 5 MI and what are the reasons for the MI. So in this patient, you know, it is a type 1 MI which occurs due to a primary coronary event such as plaque eruption or rupture. So it is very important for us to tell the type of MI, and they might ask you what are the recent classification of MI, what are the recent AHA guidelines which you need to remember. Next slide. The other most important thing is they might be asking you about the reciprocal changes. So in case in this patient, you know, it is an anteroseptal MI. So you had seen there is ST elevations in V1 to V4. They might ask what are the reciprocal changes you will see and in which leads you will be seeing. Like for this patient, if you have an anteroseptal MI, the reciprocal changes will be ST depression in lead 2, 3 and AVF. So you should be able to tell the territory, you should be able to tell the leads which have ST elevation and the reciprocal changes. Next slide. So important to remember is not all ST elevation MI have ST elevation. A classic example will be posterior STEMI where it can present with ST depression in the anterior leads and D Winters T waves. And you know, not all STEMIs can present with chest pain, but some persons can present with nausea, vomiting, or they can just present with giddiness and collapse. So important to remember is look at the ECG, look at the investigations, and call a cardiologist for immediate help and then proceed with the treatment. This pearls and pitfalls, why we have mentioned is in the examiner might ask, okay, you have already told it's an ST elevation MI with cardiac failure. What are the other things and what are the important things you will be missing in this patient if the patient doesn't present with a chest pain? So we need to tell in detail, like even if the patient doesn't present with chest pain, you should be able to tell even if patient presents with nausea, vomiting or epigastric pain, I would like to do an ECG and look for the ST changes. Next slide. Next slide. So what are the investigations? So you need to tell the investigations in order. So for all the cases here, I would like to highlight that for all the cases, the examiner will ask you what are the investigations you would like to do. You need to look at the case scenario and then decide what are the investigations you would like to ask. And you need to justify why this investigation was asked. You cannot just like that tell I need a complete complete blood count, I need lipid profile, renal function, liver function, everything you cannot tell. So if it's a stroke patient, what you need to ask? If it's a patient who comes with sepsis, what you need to ask? And you need to justify each investigation you have asked. So you're taking a cardiac case in this patient. Like if you tell cardiac enzymes, you need to tell when will I do TROP-I? Like within 6 hours if patient presence will I like to do? And what is the difference between a HS TROP-I? And what you need to do, like when will you do a NT-proBNP? What are the pitfalls of NT-proBNP? What are the causes of falsely elevated NT-proBNP? All these need to be asked, and here the discussion can go in any line. Like in case you see here you ask for complete blood count. The examiner can ask you, why do you need a CBC? The examiner can ask you, why you need a hemoglobin for this patient. Do you really need a platelet count? So you need to justify why you need each of the investigation. So for as this is a cardiac case, I would like to ask for a 2D echo, and the next definitive investigation would be to do a angiography. So you need to tell in this order, and the investigations you need to tell in the priority order, like which is the most important one and which is the definitive investigation. Like in case patient presents with stroke, you need to tell whether you need to do a non-contrast CT at present, or do you want to do an MRI with diffusion weighted imaging to proceed with further treatment. Next slide. So here I just highlighted, here you can see the ones in, why have I put up this slide is to know that which lead affects which part, like depending on the ECG, you need to tell which leads will be involved and which territory it is involving. Like in case lateral leads are involved, lead 1, AVL, V5 and V6, you need to tell the artery will be involved, will be the LCX or the LAD, diagonal branch of LAD. So you need to tell this. If your examiner is very interested, or if he is working in a cardiac ICU, he would be very interested to know which artery is involved, what are the branches of RCA, what are the branches of LAD. He might will want to ask in depth. Next slide. So what are the treatment strategies? So I have written it in a very simplified form here, but you need to tell in detail when they ask the treatment strategies. So whenever they ask you a question, you need to start with a broader treatment strategy. Like I would like to stabilize the airway, breathing and circulation. Then I would like to decide on the medical management about antiplatelet therapy. I would like to ask for a cardiologist opinion and decide on the reperfusion strategies. Or would I like to go for thrombolysis? And each of these you need to justify why you would like to do for this patient, or why is it contraindicated. Next slide. So the case we have seen now, only the first vignette we have finished. So how will it proceed next? So next they will be showing you a small thing how the case progressed. All these will be basically like your live cases which you see every day in the ICU. These will not be like how it will not be any imaginary cases. It will be like how you see every day in your ICU. So these are the basic investigations you would have done in the ER, and patient would have been shifted to ICU. So in the ICU, you do an echo, the EF is 20%, and patient has a very poor systolic function. He started on noradrenaline and the dose has been escalated, and you put him on NIV. So how does the next vignette proceed from this? Next slide. So here you can see, so these vignettes will be like, the next question would have been like, what is the role of NIV in cardiogenic shock? And you should know what is the role of NIV in cardiogenic shock. You should tell, yes, it is indicated. You should be able to tell whether it is the grade A recommendation, grade B recommendation, or the recommendation for NIV. And once you tell about this, they will move on to what are the contraindications for NIV. What are the indications for NIV? Is there any class 1 indication? What are the class 2 indications of NIV? And then they will ask, what is your plan of management from now? So would you like to intubate this patient? Would you like to put IABP? What will be your next line of management? So after completing all this, once you have stabilized the patient, at last they would ask you about counseling. Very important is how do you counsel the family? You need to know how to introduce yourself to the patient's family and how you're counseling. And that counseling the family also, like if your case is for 40 marks, sometimes 10 marks can be for counseling the family also, because communication in ICU is very important. So always remember, even in your day-to-day practice, try counseling the families and see if there is any lacunae and follow any pattern so that you don't miss anything when you counsel the family. So from this, the next vignette can move on to like, yes, this patient is planned to go on a VA ECMO. So how do you proceed with this patient? Or this patient is arrested. So how do you, what is the ACLS protocol for this patient? Can you describe the ACLS protocol? Or if the patient is declared, how do you declare bad news to the family? So so the discussion can go from here to anywhere. Or this patient is stabilized. What are you going to do for tracheostomy? How are you going to prepare this patient for tracheostomy? Or this patient is planned to shift to ward. How do you decide on post tracheostomy care? So the discussion can go from an MI to tracheostomy care, or cardiac arrest. How do you declare bad news? Or this patient develops a C. diff diarrhea. How do you manage C. diff diarrhea? What is the contact isolation of, what is the isolation precautions you take for C. diff? What are the HIC practices you have? So the discussions can go from anywhere to anywhere. So you need to know what are the questions you will be asked and how you need to answer. So I think I've told you in detail about how a case will move from where to where and what are the questions you'll be expected to do. So this is a gist of about how it's going to be, even in your mock discussions or your simulations, how it's going to proceed. I would like, next I would like to proceed with few spotters so that you will know how your spotters will be and how you should answer in the exam. Next slide. Next slide. Yeah, next slide. Yeah. So this will be your spotter one. As Dr. Alisha was already telling you, the first spotter or the first station could be drugs. So in the drugs, there could be identify the drug, how do you reconstitute and dose, enumerate its uses in the ICU. So important thing here, you could be like, it's just noradrenaline. I'm going to answer this. But remember, your examiner is smart enough to ask you, have you loaded a noradrenaline? And what does this drug constitute? And how do you load it? And what is the dose? Like, is it 0.1 microgram per kg per minute, per hour? Anything he can ask you. So you should make sure you tell the dose, how do you reconstitute, identify the drug. You should not tell noradrenaline. You should tell noradrenaline tartrate. So you should complete the drug whole name. And you should be able to tell its uses in the ICU. Next slide. So here you can see, I've just put up this slide for you to see how it is and what is the initial rate of infusion you should keep, how much you should dilute in, and what is the dose. I will not be telling you in detail in this because we have explained all these in the drugs video also. So this is just for you to know, even it's a simple drug noradrenaline, but you will get stuck if you don't keep discussing this every day in your bedside. So here you can see it is noradrenaline tartrate 2 mg per ml. So you should know how much your ampule contains and how will you dilute it and what are the uses. Next slide. So this is your next spotter. So all of you know what is this device? Yeah, laryngeal mask airway. But you should be able to describe its parts, you should be able to classify them, and you should be able to tell its users in the ICU. Few of you may be anesthetists, so few of you might be able to answer this well, but few of you might be from a medicine background, few of you might be from a pulmonology background. So make sure you know all the airway spotters better, because all these will be kept at your airway station, and you need to be able to tell the parts of the device, which class it belongs to, and its uses in the ICU. Next slide. So here I think it is not very clear, but here you can see how I've classified it into older devices, newer devices, first generation, second generation, and each of it's like LMA Classic, Unique, Pro Seal, Supreme. Lot of you might not see all these because usually we have been using iGel, which is cuffless, but you need to know at least the names when they ask you to answer in the exam. Next slide. So here you can see now we have finished with the drugs. Next we have finished with the instruments. So third spotter could be just identify the rhythm and what will be your initial steps. The most important to remember is here I've just put 4 spotters, but for you in each station, there will be a lot of spotters kept for you. And if you don't know any question, just tell them don't know so they can move on to the next spotter or the next question. Each spotter will have 1 or 2 questions. So you need to answer both the questions. And if you don't know any of the questions, just tell I don't know and move on to the next spotter. If you do not move and waste time, you will be losing marks because each station will be there only for 10 minutes. And within 10 minutes, the number of answers you answer will score you marks. Like you're stuck up with this spotter, you tell I know the rhythm, it's VF, but what will be your initial steps? You're just stuck up with this. They will not move on to the next spotter, and if this spotter is going to contain only 2 marks, you'll be getting only 1 mark. So each station try to answer all the spotters as much as possible, and if you don't know, please pass on to the next spotter so that you can complete the spotters as much as possible. Like if you answer 10 spotters, each spotter they have 2 marks, 10 into 2, 20 will be your marks. If you're just stuck up with 1 spotter in the station, then you'll get only 2 marks, whereas 18 marks you'll be losing in that station. Next slide. So here it is important when they ask you a question, you have to describe, like as I was telling you earlier, you need to describe the ECG, tell what rhythm it is. The initial steps of management will be according to your ACLS algorithm. So you need to tell, I would like to follow the ACLS algorithm. I would like to start CPR. After how many shocks would you like to give adrenaline? After how many shocks would you be giving amiodarone if it's a VF? You need to know this in by heart because each step I have marked like 1, 2, 3, 4, 5, 6, 7, 8. Each step contains marks. Even if you miss one step, they might not pass you because this ACLS station is very important for us to pass. So always remember ACLS, BLS and airway. You need to repeat every day again and again till your exam so that you don't forget any of these algorithms because you need to pass this to pass your exam. Next slide. So next slide, I've moved on to the imaging station. So here you can see it's very obvious the abnormality on the X-ray that it is a pneumothorax. So you should not just go ahead and tell pneumothorax. I was discussing earlier, you need to tell this is a chest X-ray, AP view showing what. And sometimes they might ask you how will you identify it's a pneumothorax on a lung ultrasound. You should be able to tell the lung ultrasound findings. How do you classify this abnormality and what are the modes of management? Next slide. So you should be able to tell whether it is like if it's a tension pneumothorax, what would you like to do? If it's a not a tension pneumothorax, patient is hemodynamically stable, what would you want to do? Would you like to put a 16 or 18 gauge cannula, or would you like to put a chest drain? Where should you put the chest drain, at what level? Everything has to be told in detail. So it might look very simple, but when they're asking you questions, you need to answer it as fast as possible so that you can move on to the next spotter as much as possible. Because in an imaging station, you will have chest X-rays, you will have CT images of the chest, abdomen, brain. So all of these you need to answer fast so that you will be able to score more. Next slide. So this is the end of my presentation. So I have given you a short description of how a case would proceed and an expected 4 stations, how will it occur for you. But this is just a gist. We have a lot of recordings which are available for all of these. So you can go through the recordings and ask us questions. We will always be available on the WhatsApp group to answer your questions. And remember, please do not miss your mock exams, which are live mock exams, which no other, which and I think nobody else is providing, because this is very important for you. For the uh, fear of answering questions will go, and you will come out with flying colors.
Yeah. So Dr. Jerin, yes, we will be providing you all the details. Don't worry. Okay, we'll be posting in the group, and you will get the schedule also at the earliest. So this is just one of the teaser that we thought about, like sharing with you how the exam normal process is happening, what is the best way to like prepare, and how you will be confident enough to appear for the exam. So any of the questions anyone having, please you can post in the chat box. And Dr. Ankit, if you have anything to share or anything to like guide the candidates. Thank you, Dr. Sasi, for this elaborative as well as I would say precise discussion on the exam format.
I think
Thanks.
Dr. Sashi has covered everything with a brilliant case as well. So we'll be doing such cases, and like all the previous panelists have already said, please ask questions if you have any doubts. This is the right time to ask them, and don't miss your any of the mock exams. That's all I can say. Thank you.
Yeah. So Dr. Sasi, anything you want to say, or else I would be concluding?
Only one thing I would like to say is, please do not miss your mock exams, because last time we had few students who missed their mock exams, the first mock, and they attended only the mock 2, and they were feeling bad that they were not able to attend the mock 1 exam because they had the fear of facing us, because there is no point in having fear to face us, because we are helping you to pass the exam. So you need to go ahead, fill your slots, and finish both the mock exams before your real exam.
Yes.
That's all.
So if I will be making it little bit of like flowery words, it is better to sweat in peace than bleed in war. So please, all of you, sweat in peace. That is the now time. And on the day of examination, it will be war only. So you will be having like ample opportunity to bleed there. So better don't bleed there rather than sweat in our mock exams and the discussions. Okay, so there is a question in the chat box that the candidate has to again apply for practical exams. So I would be saying that please get the message from the ICCM education only. If you have passed the Idccm, so definitely you have to apply. If you have not passed this time, maybe one session before, so you have to definitely contact the ICCM education department immediately to get the slot. Yeah, so there is a process, and it is very clearly mentioned in the ICCM website. Please contact the concerned email ID. And I think Miss Sabana is the person who will be taking care of all these.
Now Deepa is taking care, sir. There are 2%. Deepa.
Okay. Okay. So any help like this type of administrative issues, this type of like the preparatory phase, the queries, you are like free to post in our dedicated WhatsApp group, which is about to be started once the candidates would be joining. And our team, technical team, digital team will be 24/7 helping you, because you don't have much of like the time now. It would be only Dr. Sasi, when is the exam actually, if supposed to be?
Dates have not been announced, sir, but usually it will be within 4 weeks of announcing of the theory, sir. So most probably it should be in October ending or November first week.
Yes, so every day counts now, friends. So don't waste any more time and join within, like I would say, 24 hours to 48 hours, so that you will be getting all the details and not a single day would be wasted just for like thinking how to start. There is a any spotters or workstations on POCUS or ultrasound. Yes, there would be in one of the station. They would be showing you some of the small like video also, and they would be sharing with you some of the screenshots also about IVC diameter. They'd be also having like the cardiomyopathy video. They would be also sharing with you the pulmonary congestion, B lines in the ultrasound. They can like combine 2-3 video reels and ask you with a small snippet So definitely focus would be one of the important station.
Because now as we are moving towards focus, yes, there will be questions on focus.
Dr. Sunil, topics and important cases, everything would be discussed. Like no, in the as you have entered into the practical phase. In the meantime, the debrief videos, the examiners, like now our examiners would be guiding you through the important cases. Don't worry. And the WhatsApp grid is yours only, so you can post all these things so that there would be interactive discussions among your peers. Okay. So thank you very much for your the kind attention as well as joining on time. Thank you, Dr. Alisa, Dr. Sasi, Dr. Ankit, Bhagyasri, Navneet, and all the attendees. And wish you all the best. Whether you join this course or not, that's a secondary thing. But the primary thing, don't waste any more time. Be focused. Be structured in your approach and try to cover most of the things that are like in the process of your examination, and every day counts, and at the end of 1 month you would be coming up with flying colors for sure. Thank you very much. All the best.